everyone. I'm Dr. Manish Nagpal, and a very good morning, good afternoon, good evening from wherever you are located. It's a great pleasure to be always on this Orbis and CyberSight platform. I've always enjoyed all the interaction I've had in the past, and this time we are going to work on the giant retinal tears. So fasten your seatbelts and let's get on with the journey with Orbis. So giant retinal tears are any tear which is greater than 90 degrees is defined per se as a giant retinal tear, although all of them do not behave the same way. Some of them may behave like a normal retinal detachment with a smaller tear, but while some of them will have huge tears which will unfold and fold itself over the retinal surface and cause a lot of problems. Someone had asked what is the difference between a dialysis and a giant retinal tear. Well, the dialysis is basically a disruption of the retina from the ora serrata. The vitreous base is still there, which keeps the retina pretty much attached with a little fluid going in and causing a detachment. While with giant retinal tears, typically the whole retina is, the posterior part of the tear is attached vitreous base, and that's what pulls it away from that, and it kind of starts to fold. So there's a difference between the two, and the management differs a lot. Giant retinal tears come in all shapes and sizes. Of course, greater than 90 degrees, but some can be 360 degrees, some can be 200 degrees. Some of them have PVR changes, some are folded, some are non-folded. So we'll go through a lot of varieties of these as we go on. But before that, for doing these cases, one must adapt to wide field viewing systems, because without that, it's very difficult to do these cases. You need to see the periphery. And for both wide field viewing systems as well as perfluoro heavy liquid, without which giant tear surgery is almost impossible. Some of you asked this question, can we do without perfluorocarbon? I don't think today I would like to do a case without perfluorocarbon heavy liquid. Both of these, we have to thank Dr. Stanley Chang. He was the innovator for both these wide field viewing systems as well as perfluoro heavy liquids. I personally like contact-based viewing systems, and visualization is the key for all these surgeries. And my favorite go-to lenses are the Voke Minicord XL or the HRX. And now they also have a disposable one, Voke at 1. So these are what I prefer to use. A lot of you use non-contact systems as far as I know. And at this point, we would like to poll all of you as to how many of you use a contact viewing system versus a non-contact, and how many of you use a non-contact viewing system. So you can take this poll in the next 30 seconds, and we can just get an idea of who is using what at this stage. Viewing is extremely important. All the time during the giant tear surgery, you need to keep a view on what's happening in the periphery, because the tear edges, everything has vitreous attached at times, and you need to see and laser all the peripheral areas. So we have a poll of the people who are at the moment viewing it. We have about 66% versus 34% in favor of non-contact viewing system. I'm not surprised because a lot of you use non-contact viewing systems. So let's go on to now some examples of the giant retinal tears. There'll be some repetitive steps in the next few videos, but I would like to do it because it's a teaching concept, and there is a strategy to go about working on these tears. And the first thing is to get a good view. As you can see the tear as a whole. This has folded itself over the retinal surface. This cannot be seen. Your first aim is to assess how big is the tear, what is happening where, and then remove all the vitreous which is there in the core area, in the peripheral area, also the peripheral edges of the tear. Any attached vitreous should be removed. Once you are sure that the vitreous is gone, you start unfolding the tear, which is the most pleasant thing of the whole surgery, to see how it unfolds and flattens the retina using perfluorocarbon heavy liquid. And this is the reason why today this surgery is almost impossible without access to perfluorocarbon, because there's nothing else which can so beautifully flatten it passively without causing any trauma to the tear. Any other instrument you use will be traumatizing to the retina. Once it is flat, you do a 360 laser barrage. You barrage all the edges of the tear as well as the rest of the 360 area, because all these cases have predisposed weak areas in the periphery. And once the patient is taken for surgery, it's best to have a 360 barrage. Another crucial important step is that at this point I do a PFCL air exchange. I do a two-step exchange. We'll look at the exchange part a bit later, but just to show you the steps. And then once I finish the PFCL air exchange, then I top up some of the laser which is required and then put silicone oil at the end of the surgery. So I would do a two-step approach. This is another case, something similar. Again, there'll be repetitive steps, but it would be good because that's how one would know what to do when you see giant tears of different types. Again, you'll see me remove all the vitreous, assess the tear, remove also the peripheral anterior edge of the tear that you see next to the bare choroid. And once you've cleared the vitreous, you put in the perfluorocarbon, go beyond the edges of the tear, do a good laser all around, remove some of the residual vitreous if you still see it at this point of time, and then do this exchange. This exchange is very important. You have to keep the edges dry, and we'll take it up in detail a bit later. Another case where you see folded edges on the temporal side with an anterior edge and attached vitreous. And you also see multiple other tears. This is what I was telling you, that most of these cases are predisposed to having peripheral weak areas. And once a posterior vitreous detachment occurs, it instantly can cause a giant tear, and along with it, there could be multiple tears in a lot of patients. So we've removed all the vitreous, again, lasering all the edges, the horns of the tear, and removing the anterior edge of the tear, drying up the peripheral edges very carefully so that there's no slippage. And you can see that at the end, we aspirate from the disc and it's dry. And this is the stage you can put silicone oil for a tamponade post-op. Some cases you need to reach the periphery. So you can have indentation. You can do it yourself using a chandelier light source, and you can use your other hand, or you can have an assistant indent for you in case you're having difficulty seeing in the periphery. This is very useful technique in phakic clear lens eyes where you're unable to take the cutter that far periphery because you're worried about touching the lens. So in those cases, you can reduce the tone of the eye and then go in and indent from the periphery either yourself or by an assistant, so that you can bring the peripheral retina to the center rather than you taking your cutter all the way there. Now, this is a case which has two separate giant tears. Now you can see that the central part of the retina is attached, macula is on, but the patient has developed two separate independent giant tears. The treatment doesn't differ. Your aim is to do the same thing. You remove the vitreous, assess. The only thing you'll be careful with macula on giant tears is that you never want the macula to get detached at any point of the surgery. So make sure that you have perfluorocarbon on before there's any chance of a retinal elevation, and so that the macula always remains on. And then, of course, you do the same things that we discussed in the previous few cases. This is a case which was previously laser barrage. Somebody saw a giant tear and laser barraged it, but despite that, the fluid collected and went posterior. I personally don't like to laser giant tears because they have because of the sheer size and mechanics, they tend to usually go beyond any lasered areas. And by doing laser, you would have compromised some of the area of the retina because when you do the surgery, you've already lost that area of the retina with the laser, and you'll still have to do more laser in the peripheral part. So that's the only difference that would be there. Now, air fluid exchange in a normal retinal detachment is like this. You first aspirate the disc, you create bullas, and then go to the peripheral breaks and do an endo drainage. And then the retina flattens out. So this is typically how it works in retinal detachment. Now, if you do this in a giant retinal tear, it would fail miserably because of the sheer size of the tear. If you go to the periphery and start draining from the edges of the tear, it would go down instantly. There will be slippage of that tear and you'll fail. So in a giant retinal tear, I wanted to look at the exchange part very carefully. There are two ways to do it. I do a two-step approach. Now here, it's a PFCL fill eye with laser done, and I'm exchanging it to air. So I am very carefully aspirating on the edges of the tear, 360 degrees. You can see that I'm drying all the areas of the edges so that there is no fluid left, only perfluorocarbon and air is exchanging it gradually. So once I'm sure that the peripheral edges are totally dry, I would let the meniscus of the PFCL go below the edges of the retina. Before that, I would keep on making sure that all the edges are dry. So this is crucial because otherwise some of the fluid would get pushed under the retina, and which is called slippage. And after this, you aspirate the disc. Once you're sure, remove all the PFCL, and then you can put oil inside. So this is how it's a two-step approach, which is how I do all my cases. But sometimes you can get a slippage like this, and this is what is avoidable in the circumstances. So I wanted to show you a case I had a month back, a very high myopic case with a retinal detachment. And in this case, all the steps are similar. You remove the vitreous and then put in perfluorocarbon. You can see that I'm pushing the perfluorocarbon and unfolding the retina. But high myopic eyes have a predisposition to a weakness, and while doing the exchange, my cutter might have touched the choroid or something in the periphery, and at some stage, a small bleed started. You can see in the superior half here on the temporal side that a bleed has started. Now, because of the bleed starting to trickle down, it got slippage, and you can see that the blood has reached the area of the arcade, and my PFCL meniscus was gradually decreasing because of the exchange. So I instantly started putting in fresh PFCL. This is the first thing that you do, because you push in PFCL, let the blood get pushed out from where it started. And after pushing in PFCL, I aspirated most of the hemorrhage which had occurred from that edge. Also, there was a trapped hemorrhage which I made a small retinotomy and also aspirated. So this is something, a bleeding has happened, and which led to a secondary slippage. And I put in perfluorocarbon and redid the same maneuver of the exchange after that, and everything was fine. But a bleed caused this thing. So this is an example of a sort of a slippage which can occur. If it occurs, you have to go and put in PFCL again and flatten it again and do your exchange after that. I want to show you a small video of a direct exchange, which is the other way to do it. I've borrowed it from my friend, Dr. Sangeet Mittal, because I don't do direct exchange. Now, he's showing an example of how he does a direct exchange. There are, again, different ways of doing it. Some people like to put the oil through the infusion. And he basically likes to put a chandelier and then use one of the ports to put the oil, and the other port to use a soft tip to aspirate the PFCL meniscus to go down from there. So this is how a direct exchange is done, and this is used when somebody feels that they can avoid a slippage by doing that maneuver. So it's something, whoever is trained with what is more comfortable. I like a two-step approach. Also, after the exchange, I like to top up doing some laser, because your view gets much better once the peripheral view, once you have a totally air-filled eye. You can do top-up laser to the horns of the tear, which you might have missed earlier. So make sure you assess the peripheral retina at this stage, and then fill it up with silicone oil at this stage. So let me bring you another poll question at this stage of all of you who've joined. What kind of exchange do you prefer, a direct PFCL oil exchange or an indirect PFCL air and an air silicone exchange, which is what I usually do? Okay, so again, there's a 71% to an indirect PFCL air silicone exchange, and about 30% do a direct PFCL oil. That's interesting to know. So let's see some more tears. This is traumatic giant retinal tear. Again, nothing much differs in the management. You have to look at what's in front of you here. You can see admixed vitreous hemorrhage, which was there. The tear is flapping and unfolding. There's a peripheral edge, which is what, and this tear was also lasered elsewhere. You can see a small rim of laser, which was there, which it bypassed and became a full-fledged detachment. So the rest of the management is very similar. You have filled it up with perfluorocarbon, done a 360 endo laser, and then doing an exchange, making sure that the peripheral edges are dry at this stage. Now, this is a tear that you see which has a macular hole. This is traumatic as well, and a very posterior edge of the giant tear. The giant tear edges are very close to the macular area. So, and there is an adherent vitreous with a hemorrhage. So here we cleared the vitreous, then also did ILM peeling to the macular hole. And what I did is that I extended the ILM peeling right up to the temporal edge of the giant tear, because uh, the macular hole is very close to that temporal area, and we would not want a contraction happening between the peripheral edge of the tear and the macular hole. So you can see that I've done a peel and then I extend it up to the periphery to relax that area. And after that, trying to unfold the edges and then do a very mild laser to the posterior rim on the temporal side, because we have very little surface area of healthy retina in the temporal side, and the rest of the area, of course, the routine of 3 to 4 rows which are there. Now, this is a case which is almost 360 degree, but not 360 degrees, and totally folded onto itself. All you see is a bare choroid. So after we've removed the vitreous, some of the vitreous, we try to peek into to see, get a view of the posterior pole or the disc. And after slightly unfolding it, we push in some perfluorocarbon, but the inferior edge of the stair is attached. And here, because of some contraction, I'm worried that if I keep filling it, the PFCL will go behind, because inferior part has some traction, which is, there's a contraction. So what I do is I convert this tear into a 360-degree tear. I do some diathermy and cut off the inferior half so that the whole tear is relaxed, and I then treat it like a 360 giant tear and do the needful like we showed in the other cases. This is a 360-degree giant tear in a one-eyed young child, very high myopic, who came to us, a totally 360-degree tear. And the problem with this tear was that the vitreous was still attached. He was a 10-year-old boy. And after removing some of the core area, I realized that all the vitreous is attached to the rim of the tear, and that made it very difficult, because in such a situation, you do not have any hold over the retina. When you try to remove the vitreous, the retina is turbulent and it keeps on moving all around. So every time I would try to pull the PFCL, meniscus would go behind the retina. So 3 or 4 times I had the chance that every time I would pull on the vitreous to aspirate and remove it from the retinal surface, the PFCL will go behind and it becomes difficult. So at one point, I changed it into a bimanual approach. I kept a tool we call the massager, which I use as a multifunctional tool to keep the retina at bay while I remove the attached adherent vitreous. So you can see that I'm using my left hand with that instrument, which is atraumatic, to keep the retina on one side, and then with the cutter trying to remove the adherent vitreous on the edges. The triamcinolone stained vitreous is seen quite well, but is difficult to handle because the whole retina has no hold, all 360 degrees, it keeps on moving. So with some efforts, I could finally manage to get most of the vitreous out using this maneuver. You can see that how gradually we kept on peeling and removing this vitreous from each of the edges. But this is a unique challenge in young children, does not happen so often in the adults usually. So finally, I could get most of it out, and then I re-injected PFCL, and you can see that because it's a 360 tear, the retina had rotated itself with folds, and I had to re-rotate it back into a normal landscape with the normal landmarks of the disc macula. Otherwise, it had folded down towards itself. And once I'd done that, I treated it like a normal tear 360 laser and do the normal exchange at the end, which flattened the retina and then put oil inside, and the patient finally did well. Now, once you have PVR changes coming up in giant tears, so here this is a case which has a few star folds which have come up along with the giant tear. You can see there's one superiorly and one on the temporal side. So after clearing the vitreous, I put in perfluorocarbon, and once the perfluorocarbon has reached the edges of the star folds, I try to explore it with the forceps, because otherwise, again, you don't have a good hold over a very mobile retina, and the PFCL helps you assess the retinal, the membrane edges. And you can see that gradually I can release some of them, the superficial membrane of the star fold from the superior star fold, and then go on to do the same for the one which is on the temporal side. After that, you treat the tear in the same way. But you can see wrinkling here and all, and these are cases which are prone to PVR and contractions post surgery at times. Some of these cases, if there are folds which are residually there, I iron them out. You can, again, with the same instrument which I showed you earlier. This is a massager that we call. It's like a miniature version of a external indenter. It's a 25 gauge instrument, and I use it to massage some of the larger macular holes that we have. But it's also a multifunctional tool, which I showed you in some of the cases, and these are more aggressive PVR contraction cases where this tool comes handy, because here the retina folds onto itself, and to use any other instrument becomes a bit traumatic. So this has rounded edges with no sharp areas, no areas which can damage, and we gently kind of iron out these folds which have formed in the retina, so that the retinal surface can get some sense of semblance of normalcy from those folds. This is again a case of extensive PVR that you see, a lot of folds, and then the significant PVR is always going to be inferior, but of course you have to look at all 360 degrees and take care of any membranes or contractions which are there all around. So once again here, the vitreous needs to be cleared, assessed from all sides. Here also there is residual attached vitreous that you can see that we are gradually removing by using the same maneuvers, and the retina is mobile, and so you have to carefully watch how the retina behaves while you are peeling the vitreous off it. And then of course unfolding these edges of the tear and flattening all the folds so that the retina can go back, and then we laser all the peripheral edges of this particular area. Sometimes with giant tears, you can have the choroid which is very boggy, and you start the case, you thought your cannula was inside, but you had a boggy choroid, and so you might have to reinsert. Then I do it very anterior. It's a pseudophakic case, so I'm not bothered about the lens. I just pick up the cannula and put it extremely anterior, because I don't want to end up with the choroid becoming boggy, and the whole situation becomes difficult and messy once the fluid is not going into the vitreous cavity. So once you have the cannula in properly, you can the surgery becomes simpler, and you can clear up all the vitreous and proceed with the regular stuff. Put in the perfluorocarbon, eventually unfolding it and settling the retina back to its normal place. So suprachoroidal cannula can be an issue. Now this is a case with, again, some PVR changes, folded edges with choroidals which are existing in this case. So once again here you have to be very cautious, because the retina is contracted. So we put in a little bit of PFCL and then try to mechanically open up these edges, because they are full of membranes, and you have to gently unfold them, remove as many membranes, or eventually try to cut off some of the tissue which is very, very contracted. But your first aim is to save as much surface area as possible, because you are also lasering in that area in the periphery. So if you have an extra surface area, you are saving a lot more of the posterior retina which is there. Now you can see that at the end, you will see the residual choroids which are still there at the end of surgery in this situation. Now this is a case with a giant tear with a lot of extensive choroid on the temporal side. You can see this angry, boggy choroid which is there in the temporal area. So we start the case, remove the vitreous, assess the peripheral edges, put in perfluorocarbon up to the edge of the temporal side. But you can see that there is so much choroidal bogginess that I'm not able to the retina becomes, the edges of the tear are pushed by the choroid. So this is not something that it will allow the retina to settle. So I open up the conjunctiva and drain the choroid externally. You can see with the needle drainage, a lot of fluid comes out, yellowish viscous fluid which comes out, serous nature which comes out from that area, and which is what would allow that whole bogginess to come down eventually. So we've drained this externally, and then when we look back in, the choroid seems to have flattened to a large extent, and this looks much better than what we saw before, because that would have been surely something which would lead to a failure of the surgery because of an extreme underfill of the oil, which will also happen because of so much choroid which is there. So sometimes you may have to drain the choroid externally in these cases. Unfolding edges, I showed you in some of the cases. Here also you can see that to buy some more surface area, you are always better off trying to unfold and flatten, because that retina may not be very healthy. You can cut it off also, but I would rather keep it, because that's an area which is where the laser can be applied, and you can save more posterior retina for a better field of the patient relatively. And anyways, the laser is done to hold that part of the retina. So if you unfold it, you get a better surface area in those cases. So I either use the massager or a soft tip to do that in most of these cases. Now, there is a situation where you can also do a two-step approach. By two-step, I mean that you can leave PFCL inside for about 15 days or 20 days and then exchange. So this is a case where you can see a lot of PVR changes. You can see rolled up edges of the tear, wrinkling and folds which are there. And this is a situation where, again, the chances of high-risk PVR recontractions is high. So after I've removed all the vitreous, you can see how much wrinkling is there on the surface of the retina. This is not a very good sign because this indicates that this may contract. Even on table, you may be able to settle it, but it will soon contract. So I try my best to iron out and buy as much surface area as possible. But my gut feeling says that this will not stay. So here I decide to do as much as possible and then fill up the eye with PFCL totally in this situation. You can see that I'm doing a 360 laser and keeping the eye filled with PFCL, and this go back again after 2 weeks. And this is after 2 weeks. I go back in again, and you can see that the retina looks much more healthier. The folds, a lot of the wrinkling and everything has disappeared. The laser marks have taken over to a large extent, and the retina looks healthy. So at this stage, I do the air PFCL exchange at this stage, and this is more likely to stay back in place rather than if I had done this exchange in the first surgery itself. So sometimes for such cases, I would use a two-step approach where I leave intraoperative PFCL. There were some questions asked earlier, which was talking about leaving perfluorocarbons in giant retinal tears. So yeah, we used to do it in the past when 20 years back, I remember when we were not using wide angle systems and we were not able to assess. We were regularly putting PFCL for 2 weeks in the eye and then going in after 2 weeks and then removing the PFCL. And it was quite good at that time. So today I do it only for select cases which have a lot of PVR or wrinkling or contractions, and I feel that they may redetach post-surgery. So PFCL can be used post-operatively in some of these situations. This was the post-operative picture of this particular case where we put perfluorocarbon and then exchange it with oil, and it was well attached after a month of the same. Now, this is a situation where a patient operated with a giant tear with silicone oil had redetached, and you can see a pucker with forming in that area along with inferior PVR, and I'm trying to remove the pucker under the oil which you see here, and have to relax that area, and also after that trying to relax the inferior retina which had a slight contraction from that particular area. So this is sometimes a resurgery which is required in these cases. And this is what I'm worried about. If you leave wrinkled, contracted retinas, you can have at times a redetachment coming up from puckers or contractions which may happen in these situations. This is an old case. There was a giant tear with a nucleus drop inside. Now, maybe a person who was doing phaco had dropped it, and after that may have gone with the phaco probe to retrieve it, because the way the ragged giant tear had formed superiorly, you can see the edge of that tear, and the nucleus was lying in the vitreous cavity inside. So this is a situation which is quite messy. It's always good if a nucleus drops to leave it right there and refer it. But sometimes phaco probes go in with large suction in the posterior part, and that's when such a ragged tear can happen. So this is one of those situations. So here I removed some of the vitreous and immediately put perfluorocarbon, because with such a detached retina, it is difficult to remove frag the nucleus. So you want the PFCL to push back all the retina, and once the PFCL is keeping the retina at bay, you can use the high vacuum of a fragmatome to remove the nucleus. Because otherwise, if you frag it along with such a mobile retina, it is very likely that it may cause more damage. So here you see that the tear edge was going right up to the superior arcade in a ragged manner. And after removing nucleus, we put the whole tear back, retina back, and then lasered all the edges of that tear. And once it was flattened, exchange it with silicone oil. Another situation for giant tears is when it can coexist with a colobomatous eye. And we know that coloboma eyes are more prone to retinal detachments, and once in a while you get these situations because they already have weak peripheral retinas, and at times they can have a giant tear along with a coloboma. And these are usually all young patients with a lot of adherent vitreous which is there. So once again, these are situations where you have to remove the vitreous well, look at the colobomatous area, remove everything that's there, then put perfluorocarbon and try to flatten and see the whole borders between the coloboma and the retinal surface, the whole extent. And you can see that now after the unfolding, you can see that the disc is seen partially involved in the coloboma. And then you do a endo laser to the edges of the all the areas of the colobomatous area, sparing what is the macular area, of course, but the rest of it you do a good laser and also do a 360 laser and settle that particular part. So this is the post-operative picture of that particular eye that you see here. You see the disc and the whole colobomatous area which had formed, which was there, and it is properly in place. These are some of the pre and post-op pictures of tears, giant tears. Some of them are different shapes and sizes. This is the pre and the post. Immediately, what you see on the left is a recently operated one with fresh laser marks, and then you see it later once the laser marks become pigmented. This is a situation where you see a large tear which has folded itself, torn from the periphery and folded itself over the disc area, and then once it's flattened back and the laser marks are pigmented, the oil is removed, and you can see a picture of that. Then you see this again, another case which has a giant tear which we have lasered, and at the end you can see that there are a few residual PFCL. There is a bubble which is there. Now this is something which often occurs with giant retinal tear cases. Getting a PFCL bubble, which can be sometimes in the periphery, sometimes it could be a multiple bubble, sometimes it's a single bubble, because of the sheer extent of the tear edges which are open to bare choroid. So when you inject PFCL, you have to always be careful that you have no fish egging. If you have fish egging, you are more likely that some PFCL bubbles may escape into the subretinal area. And as long as they're in the periphery, you're fine. But at times they enter the space of the macular area or near the macular area, and then you may have to do something about it, where you go in and if it's affecting the macular area, you have to go and remove it. And sometimes you wait till the oil removal is required at 2 to 3 months. Or if it is extremely visually significant, you may have to go in earlier. So always be careful about injecting the PFCL. When you inject, it has to be a very slow process. Never be in a hurry to inject, because that's when fish egging occurs, and during the exchanges, some of them may go behind. Another important aspect of giant tears is that always screen the other eye of these patients, because uh, these are patients, giant tears occur in patients who have predisposed peripheral weak areas of the retina which are there, and they usually have a propensity of, whenever there's a PVD which occurs, it just rips away a very large quadrant of the retina, causing a giant tear. And sometimes these patients will have peripheral lesions in the other eye. They may have white without pressure, spanning lesions. So you have to be careful, assess individually each case, and decide to do prophylaxis laser in those cases where you feel it's required. If you see only some pigmented lattices or sheets, I would probably be conservative if it's only pigmented. But if I see associated areas which are non-pigmented or show any sort of traction, maybe I would go and laser some of these. So always look at the other eye of these patients carefully when you're assessing these situations. Uh, Getting to the end of the talk, basically, I also wanted to tell you, ask you that all of you who are involved with the retinal imaging, I at the moment look after the curation of the Retina Image Bank, which is the largest image bank, belongs to the American Society of Retina Specialists, ASRS, and I curate them. And all of you should participate in sharing your best images of any case that you have. It adds to the library there. You can go to the website of ASRS, and anyone, you don't need to be a member of ASRS. You just have to log in and have your registration done, and go to the Retina Image Bank section and upload your best images. We would like to see them, and increase the collection. And it's a huge library. Anybody can use it for teaching purposes. You can go and see almost every type of situation which is there represented in this library. And also you have a chance that we also do image of the week selections from the submissions which are there, and then there's an image of the year. So you also have a chance to win some of these image competitions which are there as a part of it. So these are some of the situations and cases that I wanted to share with you. There's a lot more which can be done with giant tears, but these are some classic situations that I showed you that we encounter routinely where giant tears are concerned. Giant tears are different than normal retinal detachments because of their sheer size and their folding onto itself, and that's why you need a perfluorocarbon heavy liquid to unfold them. That's why you need a different sort of exchange that has to be done to make sure there's no slippage and you get a good attachment of the retina. So there are peculiarities of this condition which distinctly differentiates it from a normal retinal detachment, and that is why it's important for us to know how to manage them. And here uh, the most important part is viewing, and I insist that wide field viewing is very important. Whether you use contact or non-contact is of course your personal choice, your training, your whatever you are more comfortable with. But as long as you are keeping the periphery visible to you all the times, it makes a lot of difference to this. And perfluorocarbon, there's not much you can do without it, because without perfluorocarbon, never take up this case. It will always be a challenge, and there may be slippage and a lot of other things which will come up. So somebody had asked me, can GRTs have attached vitreous and how to induce PVD in such cases? So I think you might have seen over some of these videos that a lot of them fortunately have vitreous which has already PVD is occurred and it's easy to remove. But in younger patients, very high myopic patients, coloboma patients, you may have adherent vitreous and you may have to use triamcinolone dye and keep on maybe use bimanual approaches at times, like I showed you for some of the cases. So you have to indulge in a PVD cleanup. I mean, you have to make sure that the PVD is happening. If it's not there already, you have to remove as much vitreous as possible, because otherwise the residual vitreous will contract and cause post-operative issues which are there. Somebody said, is there a role of pneumatic retinopexy in giant retinal tears? Well, I don't think personally I have much experience with pneumatic retinopexy for retinal detachments or giant tears per se. So I'm not the right person for that, but I certainly would not use it for a giant retinal tear. You get almost 100% attachment rate with the vitrectomy, and pneumatic retinopexy will have a failure rate of some sort, even in the best of hands. But having said that, I think a very superiorly located giant tear which has not unfolded itself is something that you would look at, if at all pneumatic retinopexy is something that can work in these cases. Do you prefer silicone oil for all GRT cases? And so this is something that I personally prefer silicone oil, because again, it gives me almost 100% success rate, and then you can remove it after 3 months. It does require additional surgery, but is much easier on the patient in terms of the prone and other things. With a giant tear, it also depends on which direction, which area the giant tear is there. So again, if it's just a very superior tear is where you might consider in some situations putting in gas, but otherwise I prefer oil, which is much more safer in terms of you start seeing the next day, the patient starts seeing the next day. You can assess the tear edges from the next day externally. If you have a gas bubble, all the assessment becomes difficult if at all something is happening in the immediate post-operative period. What is the role of scleral buckle surgery in managing giant retinal tears? So typically scleral buckle is not used for giant retinal tears, because if you saw the case that I showed you with the choroidals, the choroids had bulged, and what happens is that the tear edges are pushed by the choroid. Now, there the choroid was pushing, but suppose you have a buckle that you are putting, the buckle is going to give a buckle effect, which is similar to what the choroid does, and it will basically re-invert or refold edge of the tear. So this is not like a normal detachment. This is where it will push the tear edges. So the only time I think people use buckles in giant tears is with giant tear with a lot of inferior PVR, where you want to support the inferior base, but the inferior base should be attached retina and the tear should be somewhere else. If the inferior retina itself has a giant tear, then I don't think the buckle will help that, whether without PVR. But if suppose there's a superior giant tear with inferior PVR, you could use a buckle, but the buckle use is got less indentation and a much wider buckle element is used typically for giant tears, if at all you are using it in these situations. So the next question is, does one require an inverter system to use a contact viewing system? Yes. So contact system also works on the same principle. What you see is inverted and you need to re-invert. So if you are suppose using a biome, which is a non-contact system, you are using an inverter along. So the same inverter is used for non-contact, for the contact systems also. So it's exactly the same. The inverter is the same whether you use contact or non-contact. There are some non-contact don't use inverter, like IBOS, the Muller system, and some others. But Biome or Oculus, which is classically used, does use an inverter, which is similar or same, which can be used for the contact systems that I was talking about. Do you switch off infusion while injecting heavy liquid? Now, this is a very good question, because sometimes what I do is I start injecting, and there are cases, because we do at times have leaky, we use valve cannulas, and once you use valve cannulas, there is really no escape for any fluid to go in. And so whatever you inject is going to raise pressure inside. And so it's always good to assess. If you feel any resistance, yes, switch off the infusion. And in fact, I also remove some of the residual fluid to make the eye hypotonous and then inject it. Or you could do an approach where you put a chandelier light, and then you could have the left port, which was originally used for the light. You could have just externally holding any sort of a passive extrusion that you can use in that sort, which can take away the residual fluid while you are pushing the PFCL properly. So you could do it in 2-3 ways. You could either have a PFCL injecting needle, a Grizzard needle, which kind of removes the fluid, or you could have a chandelier with what I just mentioned to you, or you switch off the infusion, lower the IOP, and then inject in a few phases. You can do it 2-3 steps and fill up the perfluorocarbon. Because keep looking at the disc. If you feel that it's getting pale, you don't want that situation. Instantly, you reduce the pressure and then fill the PFCL in some of the other ways that we discussed. This problem has started happening much more because of the closed chamber, the valve cannulas. Earlier with 20 gauge surgery, we never faced this because there used to be always leaky areas from where if you inject PFCL, somewhere residually the fluid will escape and never raise the pressure. So once again, there is a question, is it possible to do giant retinal tears without PFCL? Well, I personally would not recommend. There's no reason to. PFCL is easily available, is not too expensive. In the past, its availability used to be an issue and other things, so that's different. But today, I think accessibility, availability is there, and one should always do giant retinal surgery with PFCL. Opinion on use of supplemental scleral buckles. I just mentioned to you, I personally don't use them, but the situation would be only if there is inferior PVR and a giant tear which is independent of that, maybe superior or on the sides, is where it would work. Okay, next question is 65-year-old female with total retinal detachment, OD, and myopic features, OS. Do you recommend prophylactic measures in the OS? Yes. So if it depends on what is there in the other eye. So one eye has a detachment, other eye has myopic changes. Now, myopic changes alone doesn't require prophylaxis, but suppose there are you see holes or you see tears or you see non-pigmented lattices with holes in the other eye of a patient with detachment, yes, I would like to laser. But if I just see a pigmented lattice, I would ignore it. I don't think I would go and laser it in the other eye of these patients, because there's no scientific data to prove that you're doing laser in a pigmented lattice would reduce the chance of detachment per se. So I would not do it for those reasons. Must silicone oil be useful for giant tear? Any place or use for gas? Yeah, we discussed that. So yeah, I prefer using oil in most of these cases, but gas could be used in a very specific situation where it's a superior localized giant tear which is not got folded edges, or in a situation where you're doing a two-step approach. You put perfluorocarbon for 2 weeks, you go back in, the retina looks well settled, flat. At that stage, you may exchange the PFCL with air and then put gas, is a possibility in that. Can you use Denziron instead of a two-step approach? I personally don't have experience of using Denziron, but I'm not sure. Denziron has its own issues. It's heavy silicon, removal is difficult. At times it causes some reactions, but I'm sure it can be used. It is not about replacing with a two-step approach. You may still have to do a two-step approach at times and then replace it with that. But basically, Denziron takes care of inferior part a little better, is all it does, but it does not take care of the rest of it. So I don't think I would resort to it for that reason alone. How long can you leave PFCL without any adverse reactions? Well, 2 weeks is something that, I mean, there are a lot of reports of a lot of people leaving it for 7 days, 10 days, 15 days, and In the long run, it does cause mechanical damage because of the sheer pressure of the heavy liquid which on the cells photoreceptors. But 2 weeks, 20 days is not something that you see any remarkable change from the literature, and a lot of people use it. So I would think I would keep a limit of maybe 20 days as something where you may not get a specific adverse effect because of PFCL in the eye. It doesn't cause reactions usually. The only thing you're worried about is if it's kept for too long, the mechanical pressure will cause damage to photoreceptors. How do you approach ILM peeling in detachment case? Do you peel under PFCL or under fluid? So if it's a routine detachment, I would first try without PFCL. And if I feel there is a difficulty because of the retinal mobility, I may put a perfluorocarbon and then remove it. But I will always first try it without perfluorocarbon. It's much easier without perfluorocarbon, but it just depends on the way the retina is behaving. In some cases, it's easy to remove. In some cases, it's difficult and it moves in a way that you cannot uh, remove it without perfluorocarbon. What is the prognosis of GRT in older patients as compared to young patients? It can be both ways. You can either have, I mean, a young patient has better recovery capability, while they have much more adherent vitreous and more chances of contractions and failures because of those reasons. While an elderly patient, the retina will be a little weaker than the young child's retina, but on the whole, the vitreous attachments will not be bad, and so chances of contractions and all will be less. So it totally depends on the given situations, not just about the age of the patient per se. If silicone oil while doing cataract surgery not well informed, how do you get silicone? I'm not sure I understood the question so well. What is the visual prognosis following repairs of GRTs? Well, basically, they behave like any other detachment. So, as long as you've been able to attach the macula, you can get results similar to other detachments. If it's a fresh case, you may get 6669. If it's an older case, you may get less. But if you are having a failure and PVRs, then of course the chances of visual recovery will go down. Silicone oil once inserted in eye, how long do you keep, and can it be kept permanently? Well, I always remove it around 3 to 4 months. 3 months is where we always counsel our patients that we'll remove. So uh, we check monthly and remove it at 3 months. Earlier, only if we feel that there is a high pressure which is not coming down, then I would remove it earlier. But otherwise, most patients around 3 to 4 months is when I remove it. Very rarely I keep it long. It would be in cases who had multiple surgeries and or patient have had a detachment post oil removal in the past and I've put oil again. Those cases I will keep it keep the patient under follow up every 2 months, look for pressures or look for emulsification and then only remove it. While if the oil is behaving well, I can keep it longer in those cases. Sometimes, rarely, permanently also if the oil is behaving fine because of the worry of redetachment in a one-eyed patient. So it depends on those situations, but most patients I would remove it at 3 to 4 months. In PVR cases, role of peripheral retinectomy. Yes, peripheral retinectomy is undertaken if you have contracted retina after you have looked at all epiretinal components. If you have membranes or uh, anything holding that retina, vitreous and epiretinal membranes, which you can remove, then you first remove those. After that, you assess if the retina is going back easily without a contraction. You don't need to do retinectomy. But if you feel that at that stage you have a contraction, then always do a retinectomy to relax the retina. Otherwise, you'll get a failure. Moreover, when you do retinectomy, always do it a few clock hours on both sides of the contracted element because you need to relax it properly. How do you stain ILM for ILM peeling cases in cases of macular hole with GRT under PFCL? My preference for staining is directly, and I inject the brilliant blue dye and I inject perfluorocarbon over it, and so that you get a stain under the PFCL, and then you can remove it. I don't like to inject after putting PFCL. I prefer the staining. I just inject whatever goes down, then I immediately inject perfluorocarbon. So once you've cleared the residual dye, your view is clear, and then you can see the blue stained ILM much better at that stage. Can you explain again the use of scleral buckles in GRTs? Thanks. Why to use and why not? Well, why not is because they will indent, and when a scleral buckle indents, the edge of the tear next to it will get inverted. It will push on the tear. So you are undoing what you are trying to do with a vitrectomy. With a vitrectomy, you are trying to push the retina, the tear edges back on the choroidal surface, while the buckle will push it from outside and try to act against it. So I'm not sure if it will help, but the only time you can use it is if you have extensive inferior PVR, which we discussed earlier. Do you get fogging of contact lenses you sometimes get with non-contact systems if not properly draped? Theoretically, yes. I don't get it in my ORs, but I know that probably sometimes it's based on the temperature of the ORs and humidity that uh, when I've operated in some other places, I've faced it with the contact viewing system. But I see that a lot of people get it with non-contact systems much more often, and you have to put a lot of tapes next to the breathing of the patient and all. I personally don't need to do it at all in my theaters. I never, almost never get fogging routinely because of that. Because these lenses are sitting on the cornea, and they don't have a gap in between. While with non-contact system, there is a gap between the eye and that's where the fogging takes place. What do you prefer, intraocular camera or Biomin? Intraocular camera, I'm not sure what it is. I prefer a contact system for all my cases, irrespective of the size of tear. Or what posture do you advise in patients in PFCL for keeping 2 weeks? No posture actually. I remember 20 years back when we used to do it, we used to have the patient lie totally supine for 2 weeks and not let them move. We used to be worried that something will go wrong. But over the time, we've learned that patient can move around, nothing really happens. If you have a full fill of the PFCL, usually patients are fine. If you see them after 10 days, 15 days, you may see some fish egging here and there. But I don't think you need to tell them to have any strict positioning till the time there is PFCL inside. How do you manage cases of redetachment following the removal of silicone oil? The same way as any other detachment, you go back in, put the retina back, check where it has redetached from, do more laser, put oil or gas based on what you see inside. Can you explain how to do oil PFCL exchange? Well, the direct exchange is where you put the oil through the infusion and you hold some extrusion to take away the PFCL. While the indirect is where I first replace with air and then go into oil. So it's a very straightforward way to do that. Does pigmented lattice carry risk of detachment? Pigmented lattice scientifically has no greater risk. I mean, in terms of prophylaxis. So I don't do prophylaxis for pigmented lattices. I wouldn't be worried about a pigmented lattice at all. If it's non-pigmented with holes, then and then I would look at many other factors. But if one eye has a giant tear and if patient has non-pigmented lattice, I may go and laser it. So it depends on what kind of propensity the patient has on that. Do you use dual bore cannula for injecting PFCL? Yes, it is something which can be used. I don't use it typically now. I've used it in the past a lot, but today I just directly inject most of the times. But dual bore is a very good option to inject PFCL with. An international multicentric study published by AO recommended combining buccal with vitrectomy in those less than 18 years old. Do you agree with this recommendation? No, I don't personally go by that age criteria, but yes, the only times I use a belt buckle would be in the younger patients, but not, I don't go strictly by age. I look at the type of detachment and a lot of other factors that I would do an encircling buckle with, but not for giant tears at all. This would be for uh, routine detachments with vitreous attached. What is the easiest way to remove star fold at posterior pole while doing GRT surgery? This I showed you that best is to put PFCL because this is very flappy mobile retina, and then it's best that if you can push some perfluorocarbon, which is keeping the retina at bay while you can remove it easily. If you're still having difficulty, you can also use a brilliant blue stain. It may help sometimes delineate the membrane edge better. Which silicone oil do you prefer, 1300 or 5000? I prefer 1300. I don't like 5000 so much. It's too viscous. Also, removal becomes difficult. So 1300 works good for me. Giant retinal tear with nucleus drop. The important point is that you need to keep the retina back while you do fragmentome, because a nucleus requires a fragmentome, which is a very high vacuum device. And you don't want to use a high vacuum device when there is a giant tear with mobile flappy retina. So that's the only important part that you need to be careful about. That make sure you have a full PFCL backdrop on which you do the nucleus drop, because in usual nucleus drops I don't use PFCL that often, but if it's a detached retina on which I'm doing, and especially with the giant tear, I would certainly use perfluorocarbon and on top of it do the fragmentome. Which cases do you consider removing lens even if there's no significant cataract? Today I don't remove clear lens at all. I think today's viewing systems and our instruments are so good that I don't think you need to remove the lens just because the patient has a giant tear. You can easily deal with it. Even if it's a non-significant cataract, even if there is some cataract which is not coming in our way, I prefer to keep the lens in, because till the time there is oil inside, you are better off keeping a very good compartment. It does not affect the corneal endothelium, all these other things. So I prefer having the lens inside, and maybe removing the cataract at the time of oil removal is a better idea rather than trying to. But if it's a clear lens, I would certainly not remove it at any point. How do you use the contact lens viewing? I mean, doesn't that make surgery assistant dependent? Well, yeah, you can have both ways. Contact lens can be held by an assistant with an handle, or the Voke lenses have SSV, they have self-retaining flanges. So I personally don't use an assistant. I just keep it with a Visco and keep it on and it remains fairly stable. All you need is your index finger sometimes to improve the tilt if at all you're moving the eye. But I don't have an assistant holding it, and I use all my surgeries with contact lens viewing. So you could have an assistant who is very good and understands your needs, or you can just do it without holding with having an assistant also. I don't hold it with the finger, but I use my finger to nudge it straight if at all I feel a small tilt here and there, and keep it. So just use my fingers to nudge it. How do I record such stills and videos? Well, I'm just passionate about seeing good footage on my OR and recording it. So it's something that I am constantly aware of. I keep changing the amount of gain or I have an iris adapter on my microscope, which allows me to open or shut as much as I like based on the view that I get or the brightness I get. And my recording system is a Sony one, which is allows me to have a foot switch by which I can take stills in the surgery. So at any given point during the surgery that I want to get a still, I just press another foot pedal. One of them is for the video to start and stop. The other one is for taking stills. So it's something that I enjoy capturing these moments. So I'm fond of it. So I am constantly aware of the visuals which are there. And all you need is to be looking at the screen and recording, because sometimes you get so engrossed in surgery that you lose track. So what is getting recorded is out of your field, or your brightness is not good, or if it's too bright. So make sure you see on the screen what is getting recorded, and tweak it before finishing the surgery, because otherwise your recording would have subnormal quality at the end. So just be aware of that. How do I ensure no slippage with the air PFCL exchange? What I showed you in the multiple cases that do a very good peripheral drying of the edges of the retina before you let the PFCL meniscus go below the edges of the tear. As long as the PFCL is over the tear edge, it will not slip. But once you are starting to remove PFCL where the meniscus goes below the tear edge, and if you have residual fluid in the periphery, it will go down. How to avoid lens touch during bimanual vitrectomy with chandelier? Well, chandelier will not increase any chances of a lens touch. Chandelier also stays in the same way as other ports, so I don't think it will increase. Best is that if you want to do something in the periphery in a clear lens, uh, I showed you a footage where you can lower the IOP and have an assistant indent, or you can put a chandelier, and you can with your left hand. I use my right hand with the cutter, and the left hand is something which can use indent from inside. The chandelier is giving the light. I don't need to use a fiber optic. So either way, you can achieve this kind of you can avoid the lens touch in those situations. Pretty much finished all the questions at this stage. I would like to thank all of you for patiently being here. Although this is not a forum where we can talk and interact, but I think this is the best way in terms of answering the Q&A that is available to us. And I would like to thank Orbis and CyberSight for once again allowing me to use this platform. It's always a pleasure. I almost use it twice a year, I think, over many years, and it's a pleasure to be on this forum always. Thank you very much.